Growing up, I knew my parents were there for me. We celebrated family events. They were there for me when I was sick or needed help. As me and my sister grew up, we knew we could count on our parents. We were so proud to be their children. Today, we are there for our parents, to share in the celebration of their grandchildren or to be there when they are ill or need assistance. They can count on us. And now our parents look to us to take care of them. Hello, and welcome to Always There. I'm Michael Wilsker, and I will be interviewing today a physician named David Weinstock. I am owner and president of an elder care agency called Always Best Care Senior Services, which provides in-home non-medical care and free assisted living placement. And David, or Dr. Weinstock, why don't you just give me some background about what made you become a doctor, where you grew up, where you went to school, and your current practice?
All right.
That's a lot to ask.
A lot there. So I'll tell you the short version, or relatively short. I grew up in Framingham, relatively local. Did not know I wanted to go to medical school. I went to college at Hobart College and liked biology. Not till the end of my junior years, I realized that maybe I could become a doctor. At that point, I looked around what the options would be and ended up working for a while. Then went back to medical school after I graduated. I went to medical school down in Philadelphia. Went to school down there for 4 years, but knew I wanted to be back in this area, so I moved back with my wife, Carol, to Worcester. Ended up training at St. Vincent Hospital. So I did my internal medicine residency training at St. Vincent in Worcester. I was there for 3 years for residency. I stayed for a 4th year, actually, to be the chief resident there, and then I joined Grove Medical Associates, a private practice group in Worcester. And I've been there since 2003. But like I said, I really didn't know I wanted to go to medical school until kind of late in my college career. So I worked in the healthcare field between college and medical school, which is kind of my first introduction to the healthcare world.
And what did you do in the healthcare field before you became a doctor?
I worked at Leahy Clinic. I was an ultrasound tech for 4 years there. And that's kind of where I decided I wanted to go into primary care. I saw some of the same patients over and over again, like talking with them, learning about them and their families, and obviously their illnesses. So it was kind of the beginning of what made me go into primary care. So before I went to medical school, I had kind of predetermined to go into primary care.
That's a rarity today, isn't it?
I would say definitely. There's definitely been quite a shortage of primary care for lots of reasons. But yeah, I think that it was interesting. I was back in the mid-'90s, and I remember reading articles. I was preparing for my interview at medical school. Knew I wanted to go into primary care, but realized that that was an area where schools were interested in getting students to come to the school if they wanted to go into primary care. So we're this many years later, and we're still having trouble filling those spots. So unfortunately, the steps the schools have taken and some of the funding that's been out there has not really helped that progression into primary care.
And you think you made the right decision?
Absolutely, I do. I love what I do. I certainly, it's rare that people have a vision of what they were going to be like when they were even medical school. And I always thought I wanted to be in a private practice. I wanted to make my own schedule, see my patients in a nursing home, the hospital, rehab, and the office, and it's what I do. And again, I'll be honest, it's definitely a rarity. Most physicians nowadays don't do all that, but that's what I always wanted back then, and I've been able to continue to do.
Now, I've always, some people have always had this question about what is the difference, or is there a difference between a primary care doctor and an internist?
Yeah, so it's actually a very good question. It's not uncommon. So primary care, you hear that term. So primary care is a general term for physicians, and specifically it's a breakdown. So primary care is the large group, and then within primary care you have internal medicine physicians, internist, which is what I am, which we take care of. We're essentially adult medicine doctors, so we're pretty much, generally speaking, 18 and over, and we'll see any patients from that age, 18 till I have patients who are over 100. So that's an internist, internal medicine, and also in that primary care category is also family practice medicine, and they will see kids as well as adults. And then also lumped into that group is geriatricians, which obviously specialize in geriatric care, which is generally 60 to 65 and over.
A geriatrician is a physician or like a nurse type?
No, they're physicians. So to be a geriatrician, you do 3 years of internal medicine training like I did, and they do an extra year as a fellowship, they call it, which is after residency, specializing in geriatric medicine. They'll do a lot of extra experience in neurology, in psychiatry, memory disorders, movement disorders even. So a lot of the diseases that we'll see as patients get older, they'll spend an extra year or two, depending on their fellowship, specializing in those areas.
Now, as you said before, and you touched upon this, there's a shortage of primary care doctors, correct?
Yes.
And there's even more of a shortage of geriatricians.
Yeah, if you look at the patient population, the over 65 group is probably the fastest growing group in this country. So you know, whether it's an internist or a geriatrician, there's a general, shortage of these physicians for lots of reasons, but geriatricians especially, because the odd thing about geriatricians, they have more training in there. They have to spend an extra year or two after the residency, but their reimbursement for their care is really not much different.
Right.
So unless you have a passion for that field, or then you may not spend that extra year or two becoming trained or specializing in geriatrics. So
it's driven by money.
Not driven by money, but when you're spending time as a resident, as a fellow, you don't get paid a whole heck of a lot of money. And remember, to become internal medicine physician, you're talking 4 years of undergraduate, 4 years of medical school, 3 to 4 years of training as a resident. Then a fellowship, you're looking 11 to 13 years of training as an adult before you can practice. So obviously the cost to go to medical school, and then mixed with when you're a resident and a fellow, you do make money. You have a salary, but it's certainly not. It's a very low salary.
Well, are medical schools trying to attract more students to become geriatricians? Are hospitals, is the government going to be looking to increase their income or what they bring in to? Because we're talking about it. They're saying that there's 10,000 people turning 65 every day, and that's a joke. And then by the end of by 2020, there'll be 20% of the population will be 65 and over. So, isn't there a need? Isn't there?
Absolutely.
Isn't that where the money should go? Is the funding?
Yeah.
To establish those types.
Right.
Of
I mean,
positions?
it comes down to when they do the research and looking into why people pick certain fields. Clearly, primary care has been not an attractive field to go into, financially, lifestyle, lots of reasons why. So they've tried to shift that to increase reimbursement of primary care to draw people to those fields. And they have. Things over the last several years have started to change a little bit. They have reduced what they'll pay specialists for certain procedures and testing and visits, and trying to increase a little bit into primary care. When medical students are in school trying to decide what they're going to do, there's two things lots of things they look at. One is their experience in those fields. I mean, when you go through medical school, your third and fourth year, you're spending in the office setting, in a hospital setting, and they need places to go to learn what it's like to be a primary care physician. So it's hard to get physicians to volunteer. And before, probably 3-4 years ago, you did not get paid to have a medical student come to your office to watch you, to work with you. It was pretty much, well, maybe a little bit longer than that, but over the last several years, they started to reimburse physicians for having residents in their office, which is obviously gives them the exposure. Right. So it has been a push for that. University of Massachusetts, the medical school in Worcester, has done a really good job. They were designed and developed in the 1970s to provide primary care. They've not done a great job early on. In the last 5 years, they've increased their class size. They've really pushed physicians, try to get them more involved, push their students to get more involved into primary care. So there's a push, definitely. But the other factor you mentioned, the finances, is that when medical students graduate from medical school, their debt burden can be very severe.
Well, couldn't the government try to give them more credits towards that, or try to lower the amount that they'd have to pay to go to law school to encourage and attract students to become primary care physicians?
There's definitely some of those areas that are out there, some loan forgiveness, but not a lot. I mean, the problem is, the government does pay for the majority of graduate medical education in medical school already. So the residents who are in all the hospitals in teaching hospitals are actually paid by the government as it is. The hospital gets X amount of money per resident. That money is then given to the residents. So they're already paying for our training. I would say that UMass actually has a very big program in that regard from that school. If you practice medicine in Massachusetts, you actually do get a lower rate or you pay lower towards your medical school. Your tuition is lowered for that. So there are some benefits. You see some smaller rural areas that will have loan forgiveness as well, where if you work there, they'll help pay your loans back. So there's just, again, there's part of that, but it comes down to where they want to spend the money, and that's probably going to be a bigger issue down the road with where the money's going to come from.
How does the elderly patient decide whether or not to go to a primary care physician or to a geriatrician? Or is it the primary care physician, and then the primary care physician will recommend that they go see a geriatrician? Or
it really depends. Most geriatricians will have a panel of patients. They act as the primary care physician.
What's a panel of patients?
Panel of patients is how many you'll take care of in your group. So, when you sign up, most insurances, you list your primary care physician. So if they list you as a primary care physician, that is your panel of patients. Most geriatricians will have their own, they act as the primary care physician. They just will take patients, depends, most will take 65 and over, but they'll be the primary care physician. Most internists, which I am, we see a majority of our patients are older patients. We see a lot of patients who are 50, 60 plus years old. For lots of reasons, they're the ones who have the medical problems. They're the ones who need the care. But to decide it really comes down to individual choice. If you want to go to an internist, go to a geriatrician, it really almost depends on what you're looking for from the physician. I can tell you recently, my office, we hired a geriatrician to start later this summer. When we told patients that we were hiring a geriatrician, they said, "I don't need a geriatrician. Right. I'm not old enough for a geriatrician." Right. But a geriatrician can obviously provide a lot different care than, say, I could, have a little more specialty in that group of the common illnesses.
Before we came on the air, we were talking. You mentioned to me that your panel is over 10,000 patients right now,
in
your office. Right. Well, when I think about that, 10,000 patients from one doctor is a pretty heavy load. But even for 4 physicians, a pretty heavy load.
It is.
Now, most of those patients are over 65.
It's hard to know the breakdown. It's a mix, because we definitely take care of. In my office, we're a little bit different. Probably we take a lot of care of a lot of families. We have a lot of mothers and fathers, and then their kids. So when their kids turn 18 and 20, or their grandkids turn 18 and 20, we'll often take them on. So we have many generations in my practice spanning that group. But it is a lot of patients, but they said there's a shortage in the need. So it's tough for us to say no when a patient says, who we've known for 10 years, my son's now 18, when you see him, it's hard to say no to that person.
And is that the case with most primary physicians, have that type of caseload?
In the private practice world, I think so. I don't think in primary care medicine or internal medicine, there's not really, we're not out there looking for patients. It's not very hard to build a panel of patients, build a practice to be very full. I can give you an example. With 2.5 years, we've had an internist in my practice. In 2.5 years, with very little advertising, he has over 1,200 patients on his panel in about little over 2 years. So just word of mouth, hearing from the good experience in the office, those things will drive your practice more than anything. It's hard to know what happened. I don't know what at Reliant Medical and UMass and St. Vincent, those are all their more employed physicians. So I know it's probably a little different there. They do a lot more advertising, looking to bring the patients in sometimes.
Well, let's talk a little bit about the patient that's over 65, because that's what we centralize here in this program. What are the illnesses that are that those patients over 65 are most susceptible to, and how do you work out preventing that, or do you have prevention programs for those illnesses?
Yeah, I think that certainly as the incidence of high blood pressure, diabetes, very, very common. As we get older, those are often significant problems that we're dealing with. So those are those three: diabetes, high blood pressure, heart disease are probably the 3 most common things we'll deal with. But you mentioned as patients get older, issues of memory come up, things like Alzheimer's and Parkinson's, which is a movement disorder. Those start to kind of develop, and you need to be looking for those and trying to recognize those at earlier times. From a
And
prevention,
how do you recognize it?
it's interesting.
Tests or
Well, dementia, for instance, people who have memory problems, it is rare that the patient walks in saying, we have patients who come in saying they have a memory problem. But if they recognize it, they probably don't have a memory problem.
that's what I've heard.
But certainly the husband, the wife, their kids will say, I'm a little worried about mom or dad. They forgot to pick me up, or they were driving somewhere, they got lost. They've been driving to church every Sunday for the last 30 years. They got lost on the way to church. So you do rely on input from family members. I do think that in trying to ask those questions during the visits, and try not to scare the patient, try not to make them worried about their memory, but trying to get indirect evidence that there may be some problems. So you try to screen for those things in your visits, again, trying to do it sort of, not specific questions that might ask that, but little cues that you might pick up on.
So when you meet with the patient, you're pretty much intaking the information, and then you determine whether or not you should turn it over to a specialist?
Yeah, it depends. I mean, I think every internist will have their comfort zone. They feel comfortable ordering certain medications, some they won't. Certainly when it comes to dementia, memory problems, I often will use neurologists, can often be very helpful. Having a geriatrician in our office will be helpful to have, to run those cases by them, to kind of say, okay, here's what I'm seeing, here's what the family is saying, what should we do, further testing. There are certainly reversible causes of memory problems that you don't want to miss, because there's no blood test for dementia. So I think it's helpful to do certain testing to a certain level to help kind of solidify the diagnosis or help rule out certain diagnoses. So I think it's a comfort area. Some internists will refer right away. I think it also depends on the patient. If they trust me, if they realize we're going to work together to figure this out, then I'll do as much as I feel comfortable doing. The more I can do, the better. The less I have to refer them out, the less time they have to wait, the less they worry about what we're doing and where we're progressing with it.
Let's talk a little bit about the preventive care, because we talked about that briefly before when we were talking about the illnesses. And the first thing that comes to my mind, which comes to a lot of people's minds, is the Affordable Care Act, which is the Republicans have now decided to call it the Obamacare.
Yes.
How does it work, and how does it affect your practice or practices of primary care physicians?
I think from the Affordable Care Act, certainly the intentions, like most healthcare initiatives, the intentions are very good. It often depends how it plays out, but certainly in primary care, that Affordable Care Act did increase a little bit of our reimbursement, although they took it back during the sequester, so we've lost 2% from Medicare. But so they started paying for some services that they did not pay for before. Specifically, before that came out, a routine physical exam, which most people who are younger go in once a year, get their blood work. They might get an EKG, they might get some specific testing, depending on their family history, and then you do a full exam. And Medicare did not pay for that. We often would see patients and do kind of a yearly assessment, bill it as an office visit or a follow-up visit based on their diagnoses. But we've developed, or they started paying for what they call a Medicare wellness visit, which is actually very helpful because it looks more like functional status, talking about, do they take their own medications, do they have trouble getting up out of a chair, do they have risk for falls. So it's really trying to assess the patients to prevent trying to be proactive in preventing problems or catching problems before they begin. So talking about that, we review memory with them, talk to the family about it. If they're using services like visiting nursing services, we'll often get input from them if they see some concerns at the home. So the Affordable Care Act has provided that, and they started paying bone densities and other screening tests that we do. Some of the coverages for the vaccinations, like pneumococcal, which is for the pneumonia vaccine, which are people who are over 65, the coverage for that is a little better now. The other big one now is shingles, which is approved for probably 55 to 16 over, although when it first came out, it was 65 and over. So very expensive vaccination, but can be very, very helpful. People get it, decreases their risk of having shingles. Are
there any side effects to those vaccines?
Most of the vaccines, the pneumonia vaccine and the shingles vaccine, have been very, very well tolerated, very few side effects. I think the shingles vaccine, before it was approved, I think it was tested in over 50,000 patients, showed some very good efficacy with very few side effects, and really decreased the risk of having shingles. Doesn't eliminate it, decreases the risk, or if they get an episode of shingles, it just is not as severe. I mean, it is not uncommon for someone to, as they get older, to get shingles, to be hospitalized. I had a patient yesterday who got hospitalized with shingles. So it happens, and anything we can do to prevent that, to be proactive, is obviously beneficial.
So what is, I have to assume because it's a government program like Medicare or Medicaid, the Affordable Care Act, is that has increased your paperwork, I take it?
Trying to think about the paperwork, but I mean, directly, probably, I mean, very, I would say it has not changed it that much. I mean, yeah, we do our own billing. From a billing perspective, it's always been difficult. All the billing we deal with, I don't think it's made it worse. Some of the documentation pieces are maybe a little bit more involved. We have to do what's called a patient has been discharged from the hospital or rehab setting. In order for them to qualify for services through a visiting nursing or home care, we have to do a face-to-face evaluation, which can only be filled out by a physician, not by a nurse practitioner or physician's assistant, and which is fine. We often will see the patient in follow-up. We do the paperwork then, but it's an added piece that's there that only can be done by physicians, and it's allowing others to benefit financially from it. So, and we don't directly benefit, but it provides the services, which is the most important part. So, but I think it's trying to, there's been numerous cases of Medicare fraud and problems out there. So this one layer that's built in, try to prevent that. There's millions of dollars a year wasted, and more than probably tens of millions of dollars wasted in fraud in Medicare, and they try to, let's try to catch that before it happens.
Now, you're a primary care physician. The other 4 doctors or 3 doctors in your practice are primary care physicians, and I'm sure you talk to numerous other primary care physicians in the area. What is the consensus on this program?
I think I would say the last 5 years, so before even this program came out, things started to turn a little better for primary care. The reimbursements started to go up a little bit. Again, some of the specialists were specifically cardiology. Really, their reimbursement started to go down. Some of the specialists really felt it more so than primary care. The Affordable Care Act, I think generally there's always trepidation when you're dealing with something new. I think you worry about, how it's going to affect you, more paperwork, more documentation. From our perspective, I don't think it's changed it that much. I can tell you from 10 years ago when I started practice till now, the changes have been dramatic, what we have to deal with now, but that not necessarily part of the Affordable Care Act. I mean, prior approval for medications, imaging, that didn't happen. 10 years ago, it was very little of that. Now it's every day I'm confronted with more paperwork on prior approval, but that's not directly related to the Affordable Care Act.
Now, how much involvement does a primary care physician have where, let's just say, a senior has an accident in the house, has a fall, breaks a hip, goes into the hospital, and then has to go into rehab? It's now a crisis situation with the family. Do you get involved in determining a plan for them once they get discharged? Are you involved in that?
Yes. I mean, I think speaking of personally, absolutely. And it does depend on the physician itself. Some physicians may not. It all depends on your relationship with that patient. But absolutely, if they go to the hospital and then to rehab, then from there, whether it's a placement issue, then yeah, the families will often it's very common, we'll get phone calls from the daughter saying, Mom's over at this facility, they're being discharged, can you see them, do you know them, or can you talk to them, what do you think? So we do get those calls a lot. I mean, I happen to go to rehab centers myself, I still go make rounds in the hospital, so I'll follow my patients from the hospital to rehab, so I'm actively involved in that piece. I think it's important. I mean, I can't tell you the benefit the patients, I'm sure, see when they walk in, they see a familiar face. Right. I know their history, and then when they, a hip fracture is obviously a life-altering event. The morbidity, mortality after hip fractures is devastating in the older population. So once those things happen, those are clearly signs that probably, unless it's a straightforward situation, you need to kind of readdress where they're living, the support they have at home, whether they need added services, all those things definitely. And we get calls regularly for that.
Do you get contacted sometimes by your patient has a social worker that's been working with them, a geriatric care manager, an elder law attorney? Do they sometimes contact you and come up with a plan? Do you also suggest a visiting nurse, which is for the best for them to use? Or
there's been a big push for patients who have been hospitalized to make sure they're followed up closely. Medicare has made a big push. Part of the Affordable Care Act was readmission rates for hospitals. So
Can you just briefly
yeah, so
talk
readmission.
about
So if
the
they get admitted
readmission?
with a hip fracture or heart failure is probably the best example. They admitted to the hospital. The new Affordable Care Act says if they're readmitted within 30 days, the hospital probably will not get paid for that readmission. And
So somebody who gets a heart attack is
not a heart
discharged
attack,
or
heart failure.
heart failure. It used to be where they would stay there for a week. Now they just will see it. Will discharge you, and then as an observation patient,
Right.
and then if you don't come back within 30 days, then
It's all okay.
they'll get paid.
No, but so yeah, so they really put a push towards. I think it's making people accountable. Is that so? Hospitals that they would bring people in if they discharged them too soon, if they didn't get them to rehab, and they went home. If they got readmitted to the hospital, then something probably went wrong. I mean, there's the things you can't control, but the readmission rate for heart failure, meaning that people were discharged with a diagnosis of heart failure. It wasn't uncommon for that readmission rate to be 30% of patients who were discharged ended up back in the hospital within 30 days. So the government said we don't want to be paying for essentially not poor care, but lack of very good care. So that's been a big push. So when patients are brought from the hospital to rehab, we're following them all along. In my office, we have a set program where they're called within 48 hours of being discharged from the hospital or rehab. They're seen within usually 3 to 4 days of those discharges in the office to minimize those kinds of things. But it's a big problem trying to minimize, and that's part of that is utilization of medical care. So the visiting nursing stuff is pieces will get called saying they're being discharged. We're going to have a nurse come in, do their blood pressure, check their oxygenation, check their daily weights, whatever the situation is. But we're the ones, the primary care doctor is the one who will be talking to VNA, they report to the VNA, and ultimately responsible for that care.
Well, we're almost running out of time, but I'm curious, what is the role of the primary care physician where you have a patient who's elderly, has just had a fall at home. He doesn't need to go to the hospital. He's been to the emergency room. He's been discharged. The wife calls you up and says, "This is what happened to my husband. What should I do?" Do you then suggest that they get a walker? First, you want him to come in, I'm assuming.
Right.
Do you then suggest he has a walker? He has all these other things put up in the house that would make it easier for him to get around? Do you get involved in that?
Absolutely. So that we get the phone call, obviously having them come in is ideal. Trying to identify the reason for the falls is probably the first thing you try to do. Sometimes it's tough. But the short answer is we can call a visiting nursing service, and the nurses will go out, do an assessment. They feel that PT would be helpful, OT would be helpful. We can get those services in the home. It's actually very easy to do nowadays. It's a quick phone call. We call with the right diagnosis saying they had a fall at home, they checked out okay from the hospital, they're back at home, please check them out. They can easily do that, and it's very easy to start that process, and then they see the patient, evaluate them, call us, let us know how they're doing and what they think they need, whether it's a walker, cane, or whatever.
Well, David, we're Dr. Weinstock. I call you David because I've known you for a while. Thank you for being here. There's a lot of information that I wanted to cover, but we're only getting through the first 2 pages. But I think the information you provided today will be very helpful to the viewers. So I want to thank you. Please join us on our next program, and have a great day.